My name is Dr. Anthony Lemare. I'm a cardiothoracic surgeon. Today we're going to talk about insertion of venous arterial ECMO. Before we get started though, let's define what ECMO is. Okay, so ECMO is otherwise known as extracorporeal membrane oxygenation, also known as extracorporeal life support. Essentially, it's a modification of the cardiopulmonary bypass or heart-lung machine that surgeons use in the operating room. It allows us to provide oxygen and blood to the body, essentially. Now, we like to think of ECMO in two ways. There is venous ECMO, otherwise known as venous, or otherwise known as VV ECMO, excuse me, or there's venous arterial, otherwise known as VA ECMO. Now, let's talk about VV ECMO first. VV ECMO, which I've described in a previous video, is essentially when the VA ECMO circuit is adding oxygen to blood and removing CO2. This VV circuit, or ECMO circuit, essentially is replacing the lungs. VA ECMO is a different scenario. That's essentially when the heart's not contracting well enough and perfusing the body well enough, so you're not getting oxygenated blood to the organs of the body, the brain, the kidney, the liver, and so forth. Now, before we go further, let's review the anatomy of the heart. This is a model of the heart here. I like to think of the heart in terms of sides. This is the right side, right atrium, right ventricle. This is the left side, left atrium, left ventricle. Oxygenated blood will go from the left atrium to the left ventricle. The left ventricle here will squeeze and push oxygenated blood to this structure. This is the aorta. It's the largest artery in the body. It carries oxygenated blood to our brain through these vessels. It goes behind the heart and supplies oxygenated blood to the other organs, the kidney, the liver, the extremities. If the heart's not contracting well enough, unfortunately, this process is not happening sufficiently enough to provide oxygenated blood to the body, and that can lead to poor perfusion and ultimately, unfortunately, death. And this specifically is when VA ECMO plays a role. It will basically take over the heart function. Now, we like to think of the VA ECMO insertion in two ways, rather. There is the central VA ECMO, and there is the peripheral VA ECMO. Let's focus now on the central VA ECMO. This is classically someone whose chest is already open, who already is about to have open heart surgery, or is already having open heart surgery. This is placed in patients who unfortunately need temporary mechanical support. It's either a patient who is on the heart-lung machine and can't come off, or you think their patient's going to have difficulty without the extra support. When someone is on the heart-lung machine, they have a cannula in the venous system, classically placed in the right atrium, and that's withdrawing blood from the body. And then you have a cannula in the aorta, which is providing oxygenated blood to the body. If someone is already on the heart-lung machine, essentially what you're doing is taking those cannulas and just connecting it to the ECMO circuit, which once again allows us to draw blood from the body and provide oxygenated blood back to the body. If someone hasn't already been placed on the heart-lung machine, then essentially, once again, we're placing a cannula in the right atrium, withdrawing blood from the body, and then another cannula is being placed in the aorta to provide oxygenated blood to the rest of the body. This is a scenario, once again, that is limited most likely to the heart surgeon already being in the operating room. In contrast, when someone comes into the hospital who's in cardiogenic shock, whose chest is not open, they're classically being placed on peripheral VA ECMO. In that scenario, what we'll do is we'll most likely use the femoral artery and veins. Let's use our model of the human body here. Now, we can use either the left or the right groin to gain access to the femoral artery and vein. We place a cannula in the femoral vein that will allow us to draw blood from the body. The blood will then get oxygenated, and then oxygenated blood will go back to the body through the femoral artery. Now, we can use other arteries and veins. We can use the axillary artery or vein potentially, but the quickest and probably safest way is to use the femoral artery and vein. Now, placing someone on VA ECMO, whether it's central or peripheral, is a very serious condition. The patient's classically in cardiogenic shock. Now, these patients could be on VA ECMO for several days, or unfortunately several weeks. There's lots of potential complications with VA ECMO support. You can get infection, you can get bleeding, and you can get strokes. But the benefit of VA ECMO is that it allows us to temporarily support the patient, which will allow us to either do further procedures down the road, allow the patient to recover, and also provides a little time period where we can make a decision on which way we want to go. Okay, this is just a brief description of inserting someone on VA ECMO. If you have any comments or questions, please let me know. Thank you very much.